So right now we are going to look at the basic diseases of the joints. Uh, so we are going to look at the classification of arthritis. Okay, we are going to look at hypertrophic arthritis. Okay, then we are going to look at the different conditions of this hypertrophic arthritis, like a primary osteoarthritis, degenerative arthritis, and Charcot arthropathy. Right. So first we'll start with these diseases. Okay. So, like we were talking about before, I said an arthritis is a disease that affects a joint and usually the bones on either side of the joint. For example, to say if we are talking about the knee joint, yes, proximal end of the tibia and the distal end of the femur, which are actually forming the joint, are all the one that are involved. And they are almost and always accompanied by joint space narrowing. So remember one thing that remember one thing that arthritis can be actually taken down between the joint, okay, between the bones that are actually forming the joint on either side, on the proximal and the distal, okay, and they should be a space narrowing. Space reduction in the joint space can be a feature of arthritis. So, arthritis is an inflammation of the joint and actually involves the bone that are actually forming the joint. And it is accompanied by joint space narrowing. Right. Now, whenever we are trying to look at an X ray, we have to make sure that are we looking at arthritis or if it is not arthritis. Okay. Unless and until there is some kind of a chronic change, it is technically not called as an arthritis. So remember one thing, arthritis is fairly a chronic condition. Well, it can also happen down as an acute condition too, but most of the times arthritis is mentioned down as a chronic condition, right? And the disease actually has to meet the specifications that the bones involved in the joint are, are should be, you know, affected, and at the same point of time there should be a narrowing of the joint space. We can actually see we are trying to look at the right hip joint here, and we can obviously see that there is a narrowing of the space of the hip joint, which is actually formed by the acetabulo-femoral head, right? Tabulum and the femoral head. Actually, the joint is the one that is formed there, and there is a narrowing and the reduction of the space that is present between the femoral head and the acetabulum. So that one is actually is mentioned down as an arthritis. So in this X-ray, this is the femoral head and this is the acetabulum. Okay, and you can see here there is a clear reduction of the joint space. So if this clear reduction of the joint space, it obviously indicates that it is an arthritis condition. And you can also see here that the reduction of the joint space will actually try to increase the density among these areas. And also, you can see that there are osteosclerotic changes that are seen along the articular surfaces. So, which means to say, the inflammation fluid that has been released here is actually causing up the increased density of this joint and the increased density along the articular surfaces, and the inflammation is actually caused along the articular cartilages and the articular cortex. So that's the reason there is a reduction of the joint space. So is this point clear? Right. So that is how we can actually say that this is an arthritis. So we can actually this condition is actually the osteoarthritis of the right hip joint. Okay. Right. Now, how about this condition? Well, we can actually see that there is an abnormality of the femoral head. We can see that there is an increased density, but however, you can see that the joint space is completely normal, right? We can see that the joint space is completely normal. And you can actually also see that there is a heterogeneous density along with certain areas of osteosclerotic changes that are happening along the femoral head. And there is no reduction in the joint space, which means to say the joint space is completely normal. Heterogeneous density that are seen along the femoral head. So this one particularly talks about the avascular necrosis of the femoral head, right? So reduction in the blood supply to the femoral head, one that is actually causing the avascular necrosis, and the sclerotic changes, osteosclerotic changes, along with some areas of reduced density or the radiolucency that is present here, is actually talking about the avascular nature. Well, this is not arthritis. Well, this is actually avascular necrosis, because the only single evidence how I was able to differentiate this condition, even though there is osteosclerotic changes along the articular surfaces, is that actually there is no particular joint space reduction. So joint space reduction should almost always be present down in case if you are trying to make a diagnosis of arthritis. Okay, again, is this point clear? Right? Okay. Then first we are going to talk about the main classification of the arthritis. Arthritis can be divided down into three main categories, out of which first one we are going to talk about is the hypertrophic arthritis. Okay, hypertrophic arthritis is actually characterized by a bone formation at the site of involved joints, and that bone formation may occur within the confines of the parent bone, okay, which will obviously show that the bone under stress is going to cause increased density, which can be seen as subchondral sclerosis. Okay, wherever the articular surface is actually under stress, and immediately the bone associated above it is actually called as the subchondral bone, right? And there will be increased density of that area, which is actually called as the subchondral sclerosis. And sometimes what actually happens is that there is a lot of friction and there is a lot of abuse and there is a lot of bone destruction by the osteoblast. So immediately what actually happens is that the osteocytes are the one that are actually coming down. Osteoblasts are the one that are coming down and actually forming down the new bone. Osteoclasts destroy the bone, and osteoblasts actually form the new bone. And this one eventually will cause the protrusions from that parent bone, okay? And that one will form a new bone, which is technically mentioned down as the osteophyte. So remember, in hypertrophic arthritis, there will be a new bone formation, and there will be a presence of subchondral sclerosis, and there should be presence of osteophytes. So three characteristic features: bone formation at the site of involved joints, and there will be subchondral sclerosis along the areas of friction. And then at the same point of time, you will be able to see that there will be formation of osteophytes. So osteophyte is an extra growth or the extra bone formation along the subchondral regions. So that one actually indicates that there is a lot of inflammation and a lot of abuse that is related down to the articular surfaces. So such kind of a condition is actually called as an hypertrophic arthritis, right? Then second one, we are actually having that there will be destruction of the articular surfaces, that there will be destruction or the complete inflammation of the articular surfaces, which is actually leading down to erosion. So such one is actually characterized by tiny and marginal and irregularly shaped lytic lesions. So lytic lesion is actually called as the destruction of the bone. So destruction, when the destruction is evident, which is actually going to show up as radiolucent or hypodense regions, or sometimes they can also be characterized as heterogeneous densities. So such things are actually called as osteodestructive lesions, or you can also call them as irregularly shaped osteolytic lesions. So erosive arthritis is actually characterized by osteolytic lesions, right, which are generally called as erosions, right? So this is the radiographic picture of an erosive arthritis. Then we have a third condition which is actually happening because of a infection, right? And that one will actually cause by the joint swelling, osteopenia. Okay, there is a destruction of the bone, and then again the destruction of the long and continuous segments of the articular cortex. Okay, the whole articular surface that is actually involved within the joint is actually going to get destroyed, and it is also associated with joint swelling, and such kind of condition is actually going to cause called as infectious arthritis. Remember, here the etiological factor is the infection, and particularly we are talking about the bacterial infection. And the most common type of bacteria that is actually going to cause is the streptococcus bacteria. Streptococcus bacteria are the one that are actually causing the infectious arthritis. So, in any kind of a patient who is complaining of a joint swelling, any kind of a patient who has got a gross changes of inflammation along any kind of a joint, the first thing and the foremost thing you are going to suspect is infective arthritis. Okay, infective arthritis. And in such kind of a situation, you are actually going to go for a very, very separate blood test, which is actually called as ASO titer. Have you ever heard of this test, which is actually called as ASO titers? Okay, there is a test. There is a test that is actually called as ASO. ASO is anti-streptolysin O antibodies. Okay, so I want you to actually understand one thing here. In most of the inflammatory conditions, well, it is going to get reacted down with the anti-streptolysin O protein, and it is going to form some antibodies. So increase in the rise of ASO titers or ASO antibodies are the one that is actually indicating that there is inflammation happening because of infectious condition, and most probably we are looking at streptococcus bacteria. So ASO titer, you have to understand the pathophysiology of relation or the rise of ASO titers in any given inflammation. Okay, when you have time, maybe you just try to look at this test and also try to look at the involvement of ASO as a chemical mediator of inflammation. Okay, so ASO is nothing but your anti-streptolysin. Okay, anti-streptolysin O antibody. Okay, so which is simply called as ASO titer values. So ASO titer values, if there is an increased ASO titer values, actually indicates that there is a joint inflammation, okay, which is actually happening because of infective origin, right? So let us try to look again, once again, the three categories. Hypertrophic arthritis, which is characterized by a new bone formation, and there will be subchondral sclerosis along with an osteophyte formation along the parent bone. Next, we have some erosive areas, which are actually shown as heterogeneous to hypodense osteolytic lesions or osteodestructive lesions in and around the joint surfaces, which are actually called as erosions. Then infectious arthritis are actually characterized by gross changes of inflammation, particularly joint swelling and osteopenia, which actually shows up as the destruction of the long and continuous segments of the articular cortex, and also associated with increase in the titer values of ASO antibodies. That's it. So right now we are going to look at the three given conditions. You see here, the first one, I'm going to looking at the left knee joint along the medial surface of the tibia, okay, articular surface of the tibia. I can see that there is a gross reduction, okay, a significant reduction in the joint space that is present between the medial meniscus, right? Medial articular surfaces, there is a significant joint reduction here, and I can also see that there is a subchondral osteosclerosis. You see here, there is a subchondral osteosclerosis, and at the same point of time, I can see that there is an extra bone growth formation that is seen here. So this one clearly indicates that this is the osteophyte that is present here, subchondral sclerosis that has been present here, and there is a particular reduction down in the joint space along the medial meniscus. So this one actually suggests me that I'm looking at a case of osteoarthritis, and I am looking at a right knee osteoarthritis condition. So this is a hypertrophic arthritis. All right. Next. So anything that is actually any kind of a new bone that has been formed down here can be technically called as the marginal osteophytes. Osteophytes are generally marginal. Most of the times they are marginal in location. Marginal in the sense they are happening along the surface, and they are going to happen either medially or laterally. Okay, completely outside the bone, and you can actually see them. There's an extra growth bone, extra bone growths. You can actually call them as an extra bones, which does not has nothing to do with the anatomical contour of the bone that is involved. So the parent bone here is the femur, and I can see that there is a marginal osteophyte that is present along the medial side of the femur, and there is a significant reduction of the joint space, and there is a evident subchondral sclerosis. So that one is actually suggesting me that I'm looking at a hypertrophic arthritis condition. And you see here, this one, I'm trying to look at the uh, I'm trying to look at the left uh, joint, okay, wrist joint. And here I'm going to look at the erosive arthritis, which is actually formed by the marginal retic erosions that are present down along the all the carpal bones. So how can I actually say that there is a heterogeneous loss of contour of all the carpal bones? And which actually also suggests there is a significant loss of joint space along the carpal bones, intercarpal joints, actually, that there is a significant loss of the joint along the carpal surfaces. And also I can see that there is a lytic lesions that is present down along the scaphoid bone as well. So this one actually is suggesting me that I am looking at an erosive arthritis condition. Next, the third one I'm going to look at is, you see here, there is a heterogeneous density along with the increased soft tissue attenuation here. Okay, there is an increased soft tissue enhancement, and also I can see that there is a heterogeneous density that is present along with the destruction of the cortex along the subchondral regions and extending down into the metaphysis of the tarsals here. So I am technically looking at an infectious arthritis condition. So this one is an infective arthritis, this is the erosive arthritis, and this one is the hypertrophic arthritis. So three clinical main conditions of the arthritis. Okay, three main categories of arthritis. Okay, right. Is this point clear? Any difficulty here in finding them? Right. Now, the other conditions we are going to look at is here, when these kinds of changes down are happening because of the primary conditions, which is directly related down to the bone. We actually call them as, okay, primary osteoarthritis, and secondary osteoarthritis. So this one actually is suggesting me that I am looking at a hypertrophic arthritis condition. Next, the third one I'm going to look at is here, when these kinds of changes down are happening because of the primary conditions, which is directly related down to the bone. We actually call them as, okay, primary osteoarthritis, And if it is happening because of secondary conditions, we call it as secondary osteoarthritis. Okay. Now, hypertrophic arthritis can be typified. Okay, they can be classified down into two other conditions, which is actually called as the osteoarthritis. And osteoarthritis can be technically classified again down into primary osteoarthritis and secondary osteoarthritis. So, marginal bone osteophyte formation, okay, and then subchondral sclerosis along with joint space reduction is a characteristic feature of osteoarthritis, which is also a characteristic feature of hypertrophic arthritis. So hypertrophic arthritis is nothing but your osteoarthritis as well, right? Because it is a subcategory of arthritis, right? And then at the same point of time, the patient is also going to complain that there is a neuropathic pain, or there is a sensitivity, or a a sharp tenderness that is present down along the joint. And such kind of a condition is actually called as Charcot joints. Okay, and Charcot joints are very characteristic feature of Charcot arthropathy, which is actually the neuropathic pain in the joint. Okay, every joint is actually also has got a neurovascular supply, and that one is actually going to cause you a pain, and that one kind of joints are actually called as Charcot joints. Okay, it is called as the Charcot joints. So Charcot arthropathy may also be seen in these conditions, right? Now let's try to understand. The most common form of arthritis is actually one of the most incident diseases in the world, and which actually results from intrinsic degeneration of the articular cartilage. See, over and over abuse, or over and over erosions, or over and over friction that is happening down along the articular cartilage will eventually get degenerated, right? And this one, by this, we can actually try to understand that it is also known as a primary degenerative arthritis, which means to say it is a chronic condition and it is related down to the advancement of the age. So, it is a common form of arthritis happening in the elderly because of the intrinsic degeneration of the articular cartilages. And why it is happening? It is actually happening because of the mechanical stress, which actually characterized by excessive wear and tear in only particularly in the weight bearing joints. Okay, so weight bearing joints, you can actually call them as the hip joint and the knee joint. Okay, most of the times the distal appendicular skeleton are the one that are most prone down to wear and tear. So osteoarthritis is generally seen down in the distal joints, right? And then it mostly involves hips, knees, and hands. All the distal joints, okay, is osteoarthritis. Try to remember that way. And there is an increase in the prevalence at the advancement of the age. So increase in the age increases the prevalence, and it is mostly seen along the hips and knees and hands. Right? So did you understand this? Osteoarthritis is characterized by intrinsic degeneration of the articular cartilage because of the excessive wear and tear along the weight bearing regions. And the weight bearing regions are technically hips, knees, and hands, right? And advancement of the age increases the prevalence of osteoarthritis. And it is also known as primary degenerative arthritis, right? And the imaging findings are technically same as similar hypertrophic arthritis as well, where there will be one particular sure thing, that a characteristic feature you have to find out here, that there will be a marginal osteophyte formation, okay, which is actually the hallmark feature, which means to say a confirmatory feature that is related down to hypertrophic arthritis. Okay, marginal osteophytes are formed in osteoarthritis. You have to remember it that way. And then osseous transformation of the cartilaginous excrescences, And the metaplasia of the synovial lining of the cells lead to the production of the bony protrusions near or at the joint. So what actually happens is that there will be an abuse, there will be a lot of wear and tear going on over time according to the advancement of the age, which actually causes the osseous transformation of the cartilaginous excrescence. Cartilaginous excrescence in the sense, what actually happens here is that the cartilage is going to get a lot of destruction. Then again, a new cartilage has to form. But this time, if the new cartilage is going to form, it is not going to form the same way as replacing down the destroyed cartilage in the olden times. So what actually happens that they eventually go down into the metaplasia, and synovial lining of the cells actually also produces the bony protrusions, and that one is actually forming the marginal osteophytes. So hypertrophic arthritis should be there, osseous transformation should be there, clear evidence of the wear and tear should be there, and bony protrusion should be present. So simply speaking, you can just call all of those features together as marginal osteophyte formation. And at the same point of time, only one side of the joint should be involved. For example, to say most of the times, let us try to say if you are a right leg dominant person, and most of the times what we try to do is that we start up with the right leg. Okay, so which obviously is going to put up every time a lot of stress only on the right knee joint, let's say. So if it is happening like that, and depending upon your angulation of uh, posture that you are going to maintain while you are standing, what actually happens is that yes, certain parts of the bone, particularly only single side of the bone, will be involved according to the posture that you are actually maintaining down it as a valgus or a varus, depending upon the integrity of the knee. Okay, depending upon the integrity of the knee. For example, to say, let me try to explain this one. When you are actually trying to the see what are the possible movements at the knee joint. The possible movements at the knee joint will be the flexion and the extension, right? There will be no hyperextension because it is actually reduced by the patella, right? And the medial cruciate ligament is the one that is actually going to stop you forming the varus deformity, and the lateral cruciate ligament is actually going to stop you from forming the valgus deformity, which is technically also called as that the adduction and abduction at the knee joint is not going to happen, right? Particularly adduction and abduction at the knee joint is not going to happen. So the possible movements at the knee joint are only flexion and extension, right? So let us say if a person is actually trying to stand on the right leg, what actually the one that is preventing him to doing this, preventing the adduction of the knee? It is the medial cruciate ligament, right? So the medial cruciate ligament, so which means to say the weight bearing area is going to come on to the medial side. So we are going to find out this subchondral sclerosis at the region of abuse. Did you understand this point? Yes or no? So which, actually what I meant to say is that which side of the joint is trying to prevent you from doing that abuse? And that is the side which we are going to find out the subchondral sclerosis. Is this point clear? Right? So we are going to look at the subchondral sclerosis, and this is a bone reaction which is directly indicating the amount of the mechanical stress which is subjected, and it is the protective cartilage has been eventually destroyed. So subchondral sclerosis actually suggests that the evidence of a mechanical stress is present, right? And marginal osteophytes are the hypertrophic or the metaplastic reactions that are actually going to form the new bone protrusions, right? So two radiographic features. And then sometimes we are also going to find out the subchondral cysts. Okay. Subchondral cysts are as a result of the chronic impaction, okay, or the necrosis of the bone, or the superimposition of the synovial fluid into the subchondral bone. So diffusion of the synovial fluid into the subchondral bone, or the necrosis, whichever that has been destroyed there, will actually cause cysts of varying size along the subchondral surfaces. So that one is actually going to form down the subchondral cysts. Okay, this one is also a characteristic feature of osteoarthritis. And eventually, like I said, yes, there is a hypertrophy. So there will be narrowing of the joint space that is seen also here. So four radiographic features are characteristic. Hallmark feature is the formation of the marginal osteophytes. Second one, that is going to see the subchondral sclerosis along the areas of the mechanical stress. And the third one we are going to see is that sometimes the subchondral cyst might be present along the subchondral bone or the subchondral region, and then immediately joint narrowing. Okay, joint space narrowing. So these are the four characteristic features of osteoarthritis. Right. So let's try to see here. You see here we are trying to look at the right femoral joint where there is, okay, where there is this marginal osteophytes that are formation. You see here there are marginal osteophytes that are formed here, and there is again the subchondral sclerosis that is present down along the superior surface of the femoral head and along the acetabulum, right? So both of them are actually forming down here, and there is an increased density along these areas. And immediately along the subchondral sclerosis, I can see that there is an extra ground board formation, which is actually suggesting this is a marginal osteophyte, subchondral sclerosis, and joint space reduction is clearly evident, right? And you can also see that there is a radiolucent density that is present along the acetabular surface. So all of them are the characteristic features of osteoarthritis. How can you actually remember osteoarthritis? It is happening in the inflammation that is happening because of the problem that is present down within the bone, okay? And that one is actually causing the arthritis. So what is the principal bone that is present down here? What is the weight bearing bone that is here? It is the femur that is actually bearing the whole complete weight. And the counteractive weight is actually formed by the acetabulum, right? So wherever along the joint surfaces that are actually trying to bear down the weight, which is actually the superior posterior surface of the femoral head and also the superior surface of the acetabulum, right? So both of them, that are the only areas you are actually going to see the subchondral sclerosis. See, I don't see any kind of subchondral sclerosis along this area, but I see a subchondral sclerosis only along these surfaces, right? Which is actually most active along the joint, right? So the same way how the right, the ossification centers also appear, that's the same way also certain parts of the bone will actually have the stress bearing areas. So depending upon the stress bearing areas, I'm going to look at the subchondral sclerosis only in that particular areas, right? So again, let me recall all the characteristic features here. There is an osteophyte formation, okay, right? Osteophyte formation, and there is a subchondral sclerosis along the superior surface of the superior posterior surface of the femur and along the superior acetabulum, and there is a radiolucent density that is present along the acetabulum and the complete reduction of the joint space, which is actually suggesting me that I am looking at indeed a case of hypertrophic osteoarthritis. Is this point clear right now? Yes. Is there any confusion, or is there something that you don't understand here? Right. Next, we are going to look at the Charcot's joints. Charcot's joints. Charcot joints are, like I said, that there is a neuropathic joint, okay, where there will be a lot of pain, and you can also see that there will be disturbance in sensation, okay, disturbance in sensation, which is actually leading down to multiple microfractures, okay, as well as the autonomic imbalance, which is actually leads down to hyperemia, bone resorption, and the fragmentation of the bone, right? Can somebody tell me what is hyperemia? Can somebody tell me what is hyperemia? Okay, yes, excessive, not exactly excessive blood. Excessive blood is actually called as the exsanguination. All right, excess amount of blood in the tissues, okay, is called as hyperemia. Increased blood flow, not actually excessive blood. Excessive blood is nothing but exsanguination. Accumulation of blood is exsanguination, right? This is not actually accumulation of blood. Actually, increase in the blood flow to the tissue is actually called as hyperemia. Which means to say that the all the inflammatory mediators are the ones that are being transferred here, and it is actually happening because of excess in blood vessels, and that the blood vessels is actually going to cause the increased blood flow, right? And but actually it is not about the settling of the blood. Settling of the blood is actually happening because of loss of visual striate, where there is a hypercoagulability, right? So that is exsanguination, but this is not exsanguination. This is actually called as hyperemia. Hyperemia is nothing but excess in the blood vessels, or the excess increase in the blood flow. So this one is actually happening where there is a disturbance in the sensation, and which one is actually causing the microfractures, eventually which actually triggers the autonomic nervous system, and which leads to the hyperemia, bone resorption, okay, hyperemia, bone resorption, and the fragmentation of the bone, right? Hyperemia and the fragmentation of the bone, right? So now what actually happens, generally joints do not have any kind of a sensory feedback, okay. There are technically no kind of nerves that are actually present down along the particularly iliac joint, because it is a space, right? But generally in Charcot joints, what actually happens is that these people will complain that there is some degree of pain, okay. Usually it is far less, but there will be some kind of joint destruction that is present, so there will be some degree of pain complained by these patients, right? So Charcot arthropathy is nothing but the complaint of neuropathic pain that is happening along the joint. Simple. And since there is a pain, lot of inflammatory triggering is happening. So as a result, there will be soft tissue swelling. So what is this prominent feature of Charcot arthropathy? There is a soft tissue swelling. And the most common cause of Charcot joints today is diabetes. Okay, remember, Charcot's diabetes, Charcot joints are the most characteristic features of diabetes. Diabetes is the one that is actually causing the peripheral neuropathy, right? Peripheral neuropathy, and also there will be a reduction of the increased metabolism, right? And increased metabolism is actually going to cause a lot of stress along the joints, and which is actually causing the Charcot joints, right? And it is generally seen in the lower extremities, particularly going to happen along the feet and ankles. You see here, most of the times you can feel this sensation as the pins and needles sensation in the feet. Okay, have you heard of this symptom, which is actually called as pins and needles? Pins and needles in the pins and needles in the legs. Have you ever heard of this one? Okay, it is actually, the symptom is actually called as pins and needles. Okay, which actually sounds like, actually, as if somebody is going to pierce you with the pin or sometimes with a needle. Okay, a sharp sensation that is taken along the soles and along the volar surfaces of the extremities. Actually, you will feel it as somebody is being hit by a pin, and a lot of pins, like thousands of needles. Okay, which is also called as paresthesia. I think maybe you heard this term. Did you heard this term? Paresthesia. Okay. Sensation of pins and needles inside the ankles and feet is actually called as the paresthesia, right? And that one is generally happening not because of the joint problem. It is actually happening because of the diabetes mellitus, which is a very, very characteristic feature. So, Charcot joints are generally found in ankles and feet, and it is going to cause, and this increased autonomic function is going to cause the microfractures, and that one is actually going to cause pain along the joints. And so, that one is actually called as Charcot arthropathy, right? Radiographic features, while they will also have demonstrate extensive subchondral sclerosis, right? But it is not the hallmark. The hallmark feature of the Charcot joints is the fragmentation of the bones. Fragmentation of the bones, which means to say that they will be destroyed, reduction in the trabecular parts. And also, we can also see that there will be numerous small bony densities within the joint capsule. Okay, numerous or small densities that are present down within the joint capsule, which are actually called as uh, let us say, let me see, what do we call it as? Um, why can't I remember? Okay, I will tell you just after some time. I will remember. Okay, small bony densities that are actually formed within the joint capsule. Okay, you can see that there are increased densities that are present along the joint capsule, and they are the fragments, and they are may not be reabsorbed and sometimes may not be visible. Right? You can see here. You see there are a lot of density that is the subchondral sclerosis that is present down here, and also we can see that there are a lot of densities that are present within the joint. You see here, this is the joint, here is the joint capsule, and we can actually see here that there is a some kind of increased density, and there is a subchondral sclerosis, you see here. And can you also see that the complete articular surfaces of the knee joint is lost, right? The medial epicondyle, okay, the medial surface is actually trying to articulate with the lateral. The lateral epicondyle is actually going to articulate with the medial condyle here. So which means to say there is a significant bone, okay, joint deformity that is present down here. There is a lot of angular deformity that is present here, so which is actually causing the knee to bend, right? So, and that is actually happening because of loss of integrity that is present along the joint capsule. So that one is actually called as a Charcot arthropathy. All right. And this one is now diabetes, right? This is a clinical condition of diabetes where there will be angular deformities. Okay, there will be angular deformity and increased density of the subchondral sclerotic regions. And there will be, well, actually, yes, you can call it a subluxation. Yes, particularly you can call it. But technically saying, if it is actually subluxation is the extension or the hyperextension or the hyperflexion of the joint, which is actually causing the perpendicular to the perpendicular to the line, is actually called as the subluxation. So in such kind of thing, but actually if any kind of a bone is actually causing hyperabduction or adduction, which is actually called as, which is happening away from the line, away from the central line or the towards the central line can be called as the valgus and varus deformities. So this is technically a subluxation, that's fine, but for not causing the confusion, we actually call it as valgus and varus deformities. All right, which is actually coming close to the body and also which is going away from the body, right? So this is actually varus and valgus deformity. Yes, it is a type of subluxation itself. The mechanism is subluxation, but generally subluxation we call it as if it is related down to the flexion and extension. But this one is related down to the abduction and adduction, right? All right. So this is the Charcot arthropathy, right? Right. And then radiographic features, eventual destruction of the joint will be there. And Charcot neuropathy, neuropathic pain is also seen. And that one is actually going to cause the arthropathy. Can somebody tell me right now, what exactly another condition? Is there any other clinical condition that you actually will be seeing Charcot joints? I think I remember I told you before. I think I told you before, but I don't know if you can remember it or not. Any clinical condition that you know of actually causes a Charcot joints. This is a very famous condition. No, no, no. Osteoporosis is a metabolic bone disorder. Well, SLE, not exactly. No, actually, okay. Remember, I know you can't answer. It is actually leprosy, and syphilis. Leprosy and syphilis are the ones which actually causes Charcot joints. Okay. Remember, the infections that actually causes Charcot arthropathy are the leprosy and the syphilis, and not particularly any syphilis. Okay, we actually call it as a neural syphilis. Okay, neural syphilis, which is causative organism is Treponema palladinum, and where leprosy is caused by the Mycobacterium leprae, right? Acid fast bacillus, Mycobacterium, right? Leprosy and syphilis are the ones that are actually forming the Charcot joints. Well, and I also told you about another condition which is actually called as the Charcot's joint, or that there is another thing that is actually called as a Charcot's triad. So did somebody find? I think we talked about Charcot's triad before. Yes or no? When we are talking about the GI system, I think I told you about the Charcot's triad. Yes or no? So can somebody tell me what is the Charcot's triad? Fever, jaundice, and abdominal pain. Perfect. Okay, fever, jaundice, and abdominal pain is actually called as Charcot triad. Perfect. And what is a Charcot joint? Charcot joint is the right pain, fever, and jaundice. True. Okay. Right. Charcot's joint is the one that is actually the neuropathic pain that is actually happening along the bones, okay, along the joints. In particularly in case of diabetes, it is actually called as a Charcot's joint. Now, there is another thing that is actually also known as the Charcot's neurologic triad. Okay, remember Charcot neurologic neurologic triad. Okay, which is actually happening in situation of multiple sclerosis, Okay, multiple sclerosis, which is actually showing up again three characteristic features such as speech disorder, okay, which is actually called as the scanning speech, okay, scanning speech, intention tremor, intention tremor, okay, scanning speech, intention tremor associated with nystagmus, okay, which is called as the Charcot's neurological triad. Okay, do not confuse with all these terms because most of all of them have the same name. So that's the reason I just wanted to tell you right now here itself. Okay, what are the same names that are present? Okay, so Charcot's disease is happening, which is also called as neuropathic arthropathy, right? Neuropathic arthropathy or neuralgic arthropathy, which is also called as Charcot joint, right? Which can be seen in diabetes, leprosy, and syphilis. Then there is a Charcot triad, which is actually a clinically indicating feature of cholangitis, which is characterized by pain, fever, and jaundice. Okay, right-sided upper abdominal pain along with the low high-grade fever and jaundice is actually a clinical condition actually suggesting the presence of cholangitis, that is Charcot's triad. And then there is another thing that is called as the Charcot neurological triad, which is seen in multiple sclerosis, characterized by scanning speech, intention tremor, and nystagmus. Okay, this is actually scanning speech. Okay, it's not, it is scanning speech. All right, so do not confuse with these terms. All right, right, which is a characteristic feature of multiple sclerosis right now. Okay, so in the Charcot joints, okay, Charcot arthropathy, what is going to happen that there is a neuropathy and there will be eventual destruction of the joints, which is also, okay, which is also called, let me type it for you. Okay, I think you won't, it is quite easy to remember. Okay, okay, which it is called as the lick candy stick appearance. Remember, how can we actually see here this one, which is called as the liquid candy stick appearance? How is Charcot uh, joints look like? As if there is a candy, there is a lollipop, and the lollipop has been licked. Or you can also say that there is a cotton candy, right? You guys know cotton candy, yes or no? You guys know cotton candy, right? Okay, let me show up. Who doesn't like cotton candy? Everybody likes cotton candy, right? Okay, see, and a joint actually looks like this. It looks like a cotton candy, okay, and it has been licked, so it actually appears like the cotton licked candy stick appearance. Okay, licked candy stick appearance is the characteristic feature of Charcot arthropathy. Okay, remember that way, right? Now, so you see here a lot of joint destruction that is actually happening here, and you can also see that there is a lot of inflammation that is present around, soft tissue swellings are present, and you can also see that there is a lot of distal phalanges here. So this one is actually happening because of the amputation. Okay, so diabetes has caused the amputation of the distal phalanges here, and then again you will be seeing that there will be the tarsals, a lot of destruction that is present down along the tarsals, and they look completely hazy. So this one is technically a you know uh, licked candy stick appearance. So which is actually suggesting that this is the Charcot arthropathy of the foot. Okay, and well, most of the times that there will be a total joint destruction that is happening also here. So well, and a characteristic feature, what are the most characteristics that are present down if it is happening down to diabetes? You can see it in the great toe and the tarsals. So remember, great toe and the tarsals are the ones that are more frequently involved in Charcot neuropathy. Or simply you can call it as the lower extremities or the distal joints, okay, which is a characteristic feature of Charcot arthropathy, right? Okay. Now we are going to talk about a particularly interesting condition which is actually called as the erosive arthritis. Erosive arthritis, that there will be erosions that is present along the subchondral cartilages, right? So which is a condition where the rheumatoid arthritis is classified as. Okay, hypertrophic arthritis can be classified down into three clinical conditions, which is the primary degenerative osteoarthritis, and the second one is Charcot arthropathy, right? And the second one, we are going to talk about the erosive arthritis, where here gout, rheumatoid arthritis, and infective arthritis are the ones that are coming together, right? Uh, so, erosive arthritis actually comprises a large number of arthritis, right? And where there will be some degree of inflammation along with the synovial fluid proliferation, which is actually called as the pannus formation, right? Okay, if there is a synovial fluid proliferation, which is actually called as the pannus formation, right? And actually, production of the lytic lesions in and near the joint is actually called as erosions. So small joints of the hands and feet are the ones that are going to get affected here. So, and here pannus is going to form, and the pannus actually acts like a mass of growing and enlarged synovial tissue, which actually will lead down to marginal erosions of the articular cartilage and the underlying bone disease, right? The situation, okay, let's try to understand this one here. First, there will be some degree of inflammation. Then there will be synovial proliferation, which one is the one that is leading down to pannus formation. And these pannus actually are the growing or the enlarging synovial tissues, which will eventually cause the marginal erosions of the articular cartilage. Is this point clear right now? Degree of inflammation, then there will be synovial proliferation, which eventually causes growing and enlargement of the synovial tissue. That will cause the marginal erosions of the articular cartilage, right? So, which means to say the problem has started in the synovial fluid rather than going, and which eventually is directly showing up its uh, end result on the articular cartilage, and then finally destroying the underlying bone. So that's the reason how it became as an erosive arthritis. Okay, so which actually is commonly called as the rheumatoid arthritis. Remember, it is called as the rheumatoid arthritis. Rheumatoid arthritis is a fairly a elderly disease, okay, geriatric disease. It is a geriatric disease, and it is more common in females. And also, it is characterized by a very, very peculiar feature, which is frequently involving the proximal joints of the hands and wrists. Okay, do not forget, it is actually involving the proximal joints of the hands and wrists. Okay, and it is bilateral and it is symmetrical. Remember, this is a very, very hallmark feature. Involvement of the proximal joints of the hands and wrists is actually called as the rheumatoid arthritis. Okay, all right. Is there any confusion here? Okay, and there is a a simple thing that I can tell you, how to remember the differences between the osteoarthritis and rheumatoid arthritis. Okay, but first try to remember it. It's not clear. It's not clear? Okay, okay, right, all right. See, rheumatoid arthritis is more common in female, and it is going to happen more in the proximal joints of the hands and wrists. Conventional radiographs are the choice of investigation here. Okay, right? Conventional radiograph is the choice of investigation. And you have to see that the earliest radiographic change that is going to find out here are the significant soft tissue swelling of the affected joints, and there will be osteoporosis, right? So, two hallmark features: soft tissue swellings and osteoporosis coming together, and which should be present bilaterally, and it should be present on the both sides of the joint space, okay, which is particularly seen along the articular cartilaginous areas, where there will be, rather than seeing subchondral sclerosis, where you actually see that there is subchondral destruction. Features of osteoporosis will be seen. Okay, what is the features of osteoporosis? Thinning of the cortex along with the loss of trabecular attenuation, right? So that is actually the characteristic feature of osteoporosis, right? And at the same point of time, there will be present down along the, more particularly seen along the periarticular surfaces, or we can call it as periarticular demineralization. Loss of periarticular bone mineral density along with joint swelling is a characteristic feature of rheumatoid arthritis. Is this point clear right now? Yes or no? Right? Okay. Now, the particularly thing what we are actually trying to differentiate, it is going to happen. Okay, it is going to happen, and the erosions are present down in the proximal joints. Do not ever forget this simple point here. Proximal joints. What are the proximal joints? Carpal metacarpal joints, or metacarpophalangeal joints, or proximal interphalangeal joints. Did you understand this? You see here, only the proximal joints are involved. Carpals and metacarpals, or metacarpophalangeal joints, or the proximal interphalangeal joints. So, which means to say, I'm talking about the carpals along the wrist. I am talking about the metacarpals. I am talking along the areas of palm. I'm talking about the proximal interphalangeal joints, which means to say I'm talking about the knuckles, right? Did you understand? So, what are the most involved here? Carpals and metacarpal, metacarpophalangeal joints, MCP joints, and PIP joints. Okay. See, remember it as this way: MCP and PIP is rheumatoid arthritis. Okay. See, MCP and PIPs is actually happening of rheumatoid arthritis. And what actually we will be finding out that there are two types of deformities that are present down here. Okay. Remember, this is a very, very famous question. It will be asked in so many exams. Okay. Findings of the rheumatoid arthritis. Okay. Which are actually the ulnar deviation of the fingers, ulnar deviation of the fingers at the MCP joints. MCP joints is nothing but your metacarpophalangeal joints, where there will be medial deviation of the, okay, where there will be medial deviation of the metacarpophalangeal, you know, uh, lateral deviation of the metacarpophalangeal joints. Okay, proximal joints of the wrist, yes, right? Okay, and then there will be ligamentous laxity, and which is actually going to form two kinds of deformities, which is called as the swan neck and boutonniere's deformity. Okay, you have to see the Unless we don't understand, look at the picture, you generally won't be understanding these problems. Okay, this is quite difficult to understand. Just let me find out the pictures for you and I will get it. Look at the image I sent you. Okay, look at the image I try to send you, and you have to try to understand what exactly is happening here, right? See, most of the times when you are trying to learn about orthopedics or when you are trying to learn about radiology, you know, almost every paper will have a question that is related down to this particular part here. What is exactly the difference between a swan neck deformity and a botany deformity? It can be also coming down in the diagnostics sessions as well. So try to look at the pictures I sent you, and you tell me what exactly is the difference that you are going to find out. No voice? Still no voice? Can everybody hear me? Right. So you see here, when you look carefully, when you look carefully, okay, try to look at those picture. Try to look at the picture and tell me what exactly is the difference. See, both of them, the swan neck deformity and the botany deformity, has been given there. Let me send the picture once again. Okay. Try to look at the picture and tell me what exactly do you find. Exactly. You see here, one is in the middle interphalangeal joint and other is in the distal interphalangeal joint. Right? Different joints are involved. First thing, remember, in swan neck deformity, you see here, in swan neck deformity, there will be a flexion of the distal interphalangeal joints. Okay, flexion of the interphalangeal joints. Okay, DIP, flexion of the, okay, flexion of the DIP and hyper extension of the PIP. This one is swan neck. Okay, see, distal interphalangeal joints flexion, hyperextension of the proximal interphalangeal joints is called as the swan neck deformity. Okay, and exactly the opposite is going to happen down in the Boutonniere's deformity. You see here, there is a flexion of the proximal interphalangeal joint. Okay, flexion of the proximal interphalangeal joints, and there is a hyperextension of the uh, distal interphalangeal joints. So exactly the opposite thing that is going to happen, and both of the characteristic features of, okay, both of the characteristic features of the what do you say, rheumatoid arthritis. Okay, is this point clear? How many of you people do not understand here? Right. Okay, now let me Arslan did not understand. Arslan, I think you are getting confused which one is proximal and which one is distal. What don't you understand here? Are you confused between distal and proximal, or if are you confused between hyperextension and flexion? Okay, see here. Look at the picture. Okay, now look at this picture. Look at this picture. Okay, let only Arslan talk here. Okay, look at this picture. What is the joint that is under flexion here? Arslan, only you say it. Okay, what is the what is the joint that is under flexion in this image I'm showing? What is the joint that is under flexion in this joint? Okay, to all those people who did not understand, please answer this question. Of course, it is interphalangeal. It is happening in the interphalangeals. Okay, it is happening in the phalanges. Is it happening along the proximal one, or is it happening along the distal one? Arslan, joint is under flexion. See, which joint is under flexion? Exactly. So distal, right? Distal joint is under flexion. Perfect. You see here, distal joint is under flexion. And you see here, so this one is the distal interphalangeal joint. So which means to say this one becomes the proximal interphalangeal joint. So how is the proximal interphalangeal joint? Yes, which obviously should have been in flexion, but it is not in flexion, but it became hyperextension. So that's the reason you see here there is a curvature. So hyperextension of the proximal interphalangeal joint along with flexion of the distal interphalangeal joint, or hyperextension of the PIP and flexion of the DIP is a characteristic feature of swan neck deformity. Right now, is it clear? Yes. For all other people, yes or no? Right? It's just something, because you see you did not understand it there because you don't know which one is proximal, which one is distal. And also the same way you are unable to differentiate what is the hyperextension and what is the flexion. So remember, swan neck deformity is going to cause, okay, flexion of the DIP, distal interphalangeal joint flexion, and hyperextension of the PIP, proximal interphalangeal joint hyperextension. So that is swan neck deformity. And Boutonniere's deformity is the hyperextension of the DIP and the flexion of the PIP. Clear? Arslan, is this clear? Right? Please do not confuse. Yes. So the picture I showed you is the swan neck deformity. Right? Okay. Now let me show you another picture so that you can actually try to understand. Uh, let me give me a second, please. Okay. Look at this picture and tell me which bones, which phalanx, okay, which phalanx has got the problems. Okay, use this image as the reference. Use this image as the reference. Or you can also try to use this one. So if you can answer this, exactly you have understood what exactly I'm talking about. No, I'm asking which phalanx, the number of the phalanx, which one has got Boutonier's deformity and which one has got this one. Okay, all right, all right, all right. Okay, what about the second picture? Oh, sorry, third picture. What is third picture? What about the third picture? See, there is a swan neck deformity of the second uh, phalanx, and there is a Boutonier's deformity that is present on the third phalanx, right? Yes or no? Perfect, right? So now is it clear? Right. Okay. Now, so this one is swan deformity and Boutonier's deformity are the ones that are actually showing up the rheumatoid arthritic features. Okay. Metacarpo-interphalangeal joints. You see here, and there will be a lot of osteoporotic changes that are seen here. See, and there is a subchondral osteoporotic erosions that are seen, and also you see here there is the metacarpo-interphalangeal joints. Okay, metacarpo-interphalangeal joints that are present down here. So which I'm looking at the knuckles. So this one are the involved, right? So such kind of a deviation, so ulnar deviation happening, okay, ulnar deviation along the metacarpo-interphalangeal joints is a characteristic feature of rheumatoid arthritis. Okay, and subluxation of the metacarpophalangeal joints. Okay, and ligamentous laxicity. Ligamental laxicity is actually the ligaments actually tend to hold up, the what you call it as a permanent spasm of the or the permanent stiffness that is related down to the ligaments is actually seen here, which is actually called as ligamentous laxity, right? Where the ligaments try to hold down the joint in certain position permanently. Okay, so what is the characteristic feature of rheumatoid arthritis? It is the joint stiffness. So, which is also called as the early morning joint stiffness. Okay, I think you might have heard about this symptom, early morning joint stiffness associated with the pain. Okay, and ulnar deviation of the hand is actually called characteristic features of rheumatoid arthritis, right? Okay, and you see here in the wrist, erosions of the carpal bones are actually seen here, and the ulnar styloid process. Okay, and there is a complete narrowing of the joint space. Okay, there is a complete reduction of the joint space. Okay, this one ulnar styloid process. Okay, and there is a little bit of erosion of the ulnar styloid process, and there is erosion of the carpal bones. So this one is completely showing up your characteristic feature of rheumatoid arthritis. And don't you see that there is a deviation, a little angular deformity that is present out here? So that is actually rheumatoid arthritis. Okay, and carpals ulnar. and radial ulnar joint, most of the times wrist joints and metacarpointerphalangeal joints. Okay, and the proximal interphalangeal joints and the distal interphalangeal joints are the ones that are most commonly involved. Okay, generally, if it is happening, if rheumatoid arthritis is going to happen in larger joints, it is not going to show up erosions, but there may be marked uniform narrowing of the joint with no or subchondral sclerosis. Okay, subchondral sclerosis generally will not be present, but uh, you know, narrowing of the joint space can be seen, right? Okay, so this is the characteristic features of rheumatoid arthritis. And now you see here, my voice is broken, still broken. No voice, still no voice.